What do we mean by regular follow-up? Regular follow-up is check for milestones. Very important. HIV encephalopathy comes much earlier. Milestones. Look for failure to thrive and look for organomegaly, lymphadenopathy. So lymph nodes coming up, liver spleen coming up, failing to thrive, milestones are bad, then you know this child is getting positive. At 3 months this child is negative, we did his HIV DNA PCR, he is positive. So is he infected? Is he infected? We have to repeat, right? We repeat. So this child was staying some 700 kilometers away from Mumbai. So by the time he came for the next visit, it was 6 months of age. This time he is weighing 7 kilos. So he is growing really well. There is no problem. We repeat a test, he is positive. So what does this tell us? So 2 tests positive, this child is HIV infected, though he is asymptomatic. So what should we do now? How many times incorrect? We already confirmed it twice, and PCR is not cheap. PCR costs us 2,000 rupees. Why do you want to do a viral load? So if we want to decide to start ART, this child is asymptomatic. So we have to decide whether to start ART or not. So we do a viral load. Okay. Fine, at 7 months when he came, we did a viral load. Now viral load is less than 20. They need at least 20 copies of the virus to detect the virus. They did not even detect 20 copies. That means they could not detect the virus in the viral load. So viral load is undetectable. We did a CD4 count which is band normal, or like a normal child. But we have done it by 2 separate kids. So what is it? Is it positive or negative? You're labeling, the parents are anxious, you're calling them again and again. You're telling them, I don't know what your report is. First time you said we'll do it, second time. Second time you said, oh, both 2 reports positive, he's infected. We have to start him on treatment. Then he came for treatment with the viral and you said, oh, I'm not sure what this report is now. I don't know whether he's positive or negative. So you can imagine this patient will leave you and go to another doctor. Kits may have expired. The ISI recognize labs. They cannot play around with it. Presentation may be delayed, agree, but then why this viral load is undetectable? Why the series 2 is one of those long-term non-progressive where they are positive but they don't have the virus? Possible. But then how do we follow this child up? So we'll tell them, oh, no, you're still positive, you're that long-term non-progressive. Follow how?
After 6 months.
After 6 months do what?
Then we know if the child is more than a year, then it's 18 months, then we can do the...
So we are not sure. First thing in the back of our mind, we are not sure that this child is positive or negative. So it's better to be safer and say, we'll not start you on any therapy. We'll repeat an ELISA at 18 months. Correct? The earlier the maternal antibodies start disappearing, by 6 months they start disappearing. So we could be safer in doing an ELISA at 9 months. So we did an ELISA at 9 months which came non-reactive. Does that tell me it's negative? No. There could be a transient hypogammaglobulinemia in the child. Means he is not developing his own antibodies. That's why the ELISA may be negative. So we waited till 18 months. 18 means child asymptomatic, weight 11 kilos. He is growing really well. HIV ELISA negative, Western blot negative. So what is this child finally? Finally the child is HIV negative. So why did we get those PCRs positive? You know, when we started facing this problem, I went to all the labs in Mumbai myself and saw how they were doing the PCR. And I realized that the PCRs that they were doing were wrong. When you talk about books mentioning PCR gold standard in infants, they talk about standard kit. So it's a Roche Ampiclot kit that is available. Everything is set, everything is automated. You just put the blood sample and take a reading after 3 to 4 hours. If we do that, the cost of your PCR would be 8,000 rupees. Because we can't afford, what our labs, Indians are very smart. What we do is we get the technology and make our own thing, right? So we got the technology. We understood the principle. PCR, we amplify a certain region of the virus, right? So we need certain primers to amplify it. So they bought their own primers. And they amplified that region of the PCR virus. and then they run the PCR and look how much is the virus, whether the virus grows or not. Now all this is not automatic. Okay, everything is manually done. So you may have contamination occurring. Then final reading may be on agar gel, or it may be on colorimetry. Again, those are not reliable. So our PCRs are not standardized. So when we ask for a PCR, be sure which method they are going to use. Are they going to use a standard kit, or they are going to do their own in-house PCR? If they are going to do their own in-house PCR, take it with a pinch of salt.
So which are the lab who is doing the standard? Where to say?
So find out from the lab whether they do a Roche antichlor method or not. If they are doing that, you're fine. If they're not, then take it with a pinch of salt. We stop doing PCRs.
One lab is giving 1 day the test, and the other lab is saying come after 4 days. What is the external?
PCR takes time to run.
So the 4 days will be more.
No, all your PCRs will be taking time. Even when you have an automatic PCR which takes 3 to 4 hours to get your report, they will not run that test for one blood sample. So they will wait for 2-3 samples to collect, and then they will run the
So
test.
that 1 day, 1 hour also is right.
Yeah?
Okay.
But find out whether it's a standardized kit. We have stopped doing PCRs. I don't do PCR, especially if a child is asymptomatic like this. I do a viral load only if the child I find is having symptoms.
So, but madam, tell the names of the labs, like micropolitan, like.
I'm on camera.
Okay, that's the camera. Because see, we are.
This is every lab.
Huh.
Every lab. I've gone to Thane, I've gone to Worli, I've gone to every lab. And this is a problem in every lab.
They are charging. Because I am taking from with Leela
Yes. 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 So always, whenever you ask any microbiologist who's running a PCR and ask them, they'll always tell you interpret it clinically.
No, but clinically, madam, see, somebody is exposed. Somebody wants to know whether it's positive.
I tell the parents, keep patients. You kept patients for such a long time, keep patients till 18 months. Until unless I have a child who's very symptomatic and I want to start him on therapy, then I would do a viral load and see whether those viral loads are 5 lakh, 6 lakh copies or whatever. But most of them do have the patience to wait. Instead of giving them that trauma or positive report and then saying, no, now wait, it's better. And how much did we get positive? We are getting false positive to the tune of 57%. That's very high for us. That means half of the patients that we are testing are false positive. So this is too much of a problem. It's better not to do this. So for us, PCR is not the gold standard. We still have to wait for an ELISA. So what did we conclude? That prevention of HIV is possible. Goal is no transmission and interpret reports with care. Two things. One is ELISA's problems. Second is this PCR problem. So now you understood why I say that be very careful when you diagnose HIV. I've had enough patients who come to me PCR positive, started on ART and then referred to me. And then I will tell them stop the drug. Very dangerous. Okay, now TB. TB, what happens? We all have dealt with TB. It's common at all age groups, children, adults, old people. In children, commonest age is 1 to 5 years, and pulmonary TB is the commonest manifestation. Now, what are the types of TB? WHO has recently classified TB as pulmonary versus extrapulmonary. But what has happened in that classification is that pleural TB becomes extrapulmonary. Mediastinal TB becomes extrapulmonary. So we have all the TBs which are actually we used to say pulmonary TB have become extrapulmonary. So now we have extrapulmonary pleural TB, TB lymph nodes, TBM, TB serositis, abdominal TB, bone TB, all of them becoming as extrapulmonary. So how do we, and treatment wise we say Cat 1, Cat 3, Cat 2, category, all those. So what I have decided is we label them as chest TB versus non-chest TB. Now what is chest TB? Chest TB is pleural effusion, primary complex, primary progressive, mediastinal adenopathy, fibrocavitary, pericarditis. So any TB in the chest is chest TB. And why is it important to label as chest versus non-chest? Because your symptoms are the same. Even if I get a pleural effusion, my symptom will be fever, cough, breathlessness. Even if I get a biliary TB, my symptom will be fever, cough, breathlessness. My TB lymph node is not going to come like that. It is going to come as a swelling. TB meningitis is going to come with headache and fever. So it's important to know it as chest TB. Now, can we differentiate clinically on the basis of these six as which are the types of chest TB? Clinically. Clinically means my symptoms of fever, cough, loss of weight, loss of appetite and breathlessness. Can I differentiate? When we think of it, we think, no, we can't differentiate. Everything is the same. We can. How do we? Now, let's take this case. He's a 2.5-year-old boy. He's come for fever for 2 days and cough. On examination, he's breathless with tachypnea. Tachypnea, last lecture we had respiratory rate shallow and rapid, oxygen problems, so there is a pneumonia. Okay? He is having a bronchial breathing in the right intramammary region with crepitation. So there is a patch, consolidation. His height and weight are normal and symptoms are only 2 days. So is this TB? No. This is a pneumonia. A pneumonia with a consolidation of 2 days. So this tells me this is bacterial pneumonia. So I would treat this child as EKG, with antibiotics. Now this is the X-ray. What is the X-ray showing? Right, there is a right lower lobe consolidation. So my diagnosis is pneumonia. And I treat this child with antibiotics. I find he doesn't respond.
Did you see Pediatric also?
Yeah, something here. What is that? In a child, this could be a thymus, or this could be a lymph node. If there is a lymph node here and there is a pneumonia here, why a lymph node and a pneumonia? Primary progressive. That means there is this lymph node which is compressing the bronchus. Secretions are accumulating, which is getting infected here. So primary progressive TB. So if I see this X-ray, it does not tell me bacterial. It tells me this is primary progressive TB. Primary progressive TB presents just like a pneumonia with an acute onset symptoms and no failure to spread. So this may be TB. Now what has happened here? This is what we saw. Right lobes and consolidation with superior mediastinal widening. Marker in this child was 8/8, not very significant. You need more than 10. WBC count is normal. For a pneumonia, WBC count normal, something tells you it's not right. ESR is 30, GLAF is negative. You treated for antibiotics for 2 weeks but had no response. How do you prove this is TB?
Can two tests is done with what TBs?
Let's take 10 PU.
Then it will be showing, should be right TB or?
Yeah, if I use 10 PU, it should even be higher than it should more. Yeah. So how do I prove? He didn't respond to the antibiotics. That tells me that the pneumonia did not respond to antibiotics. So it tells me this may be TB, but now it's the era of evidence-based medicine. I just can't start empirically ATB. How do I prove this is TB? Lymph node biopsy in the mediastinum?
CT you should.
How? Bronchoalveolar lavage means I put the child under GA under operation theatre and send them. Any non-invasive? How is the CT help? It will show me a lymph node. It will show me caviation and necrosis in the lymph node. If I can see caviation and necrosis in the lymph node, this is tuberculosis. So we didn't get anything here. We did a CT. It shows a right lower lobe consolidation. There is a large caseous necrotic lymph node in the mediastinum, the right pretracheal and the right hilar. So what is important is the caseous necrosis. This tells me this is TB. So I didn't have to do bronchoalveolar lavage, I didn't have to do a biopsy. So I avoided all that.
If you don't want to go for CT, to cut the cost, again repeat the same lesion source.
Agreed, that's what. That is what I am saying. After 2 weeks of antibiotics, X-ray is the same, there is no improvement.
Can we empirically start?
You are in the era of evidence based.
We have to confirm.
Yes, you should. You should not overtreat. That is my message. So CT would be an important criteria. Our diagnosis here was primary progressive TB. Let's take a second case. 2-year-old boy, dry cough for 1 month. No fever, there is loss of appetite, but there is no cough contact. What do you think is the problem? He's got dry cough for 1 month.
put in our mind.
Don't think of TB, think of all other possible causes.
Allergy. Allergy.
Allergic, okay, it could be asthma, right? Allergic cough. Then, but allergic cough would be more at night time. Dry cough means there are no secretions, right? There is no secretions coming out, so it's not a pneumonia. So dry cough, something, it can be the nose. Nose can't cause me a cough without a cold. It has to be pharynx. So pharynx can cause me a dry cough. Pharyngitis going on for 1 month, unlikely. Then that leaves me with trachea. Trachea, dry cough? No, tracheitis means difficulty in breathing. Bronchi, dry cough can be a symptom, but more at night. So bronchitis. Bronchioles, 2-year-old child would have had breathlessness, not as a cough. Pneumonia, wet cough. Then I come to pleura. Pleural effusion, dry cough. Pleural effusion going on for 1 month without any other symptoms, unlikely. So that means there is either a bronchitis or there is some lesion in the lung which is not within the alveoli, but it is in the interstitium. So which interstitium? So is it primary complex? Yes, primary complex can cause a dry cough. Is it a mediastinal node which is compressing and irritating? Yes, that can cause a dry cough. Is it miliary TB? That can also cause a dry cough. So my diagnosis here is asthma, it is miliary TB, it is primary complex, or it is mediastinal lymph nodes. That's my diagnosis of a dry cough going on for 1 month. Now out of all that, we come to his height and weight. Most important. He is well nourished. Bronchitis still possible. Primary complex still possible. Mediastinal adenopathy still possible. Miliary TB is out. Okay, so now I am left with 3 diagnoses. So now there are 3 diagnoses. Examination I didn't get anything. So all these 3 are possible still. So what will we do? Chest X-ray. Okay, how will the chest X-ray help us? Okay, so we want to look for lymph nodes, mediastinal adenopathy, so chest X-ray. We can pick up primary complex. Bronchitis, it will not help us. So we did an X-ray. Now this X-ray, you can see there is some amount of widening of the mediastinum. And there are some shadows here. This could be primary complex with lymph nodes. This could be mediastinal adenopathy. How do you prove that? Again. This child turned out to be marker positive. Diagnosis was mediastinal adenopathy in this child. And then HRC. So dry cough going on for more than 2 months, 2 weeks is a presentation of TB. And you will not get any other features. No weight loss, no fever, just cough.
Dry cough?
More than 2 weeks. Any cough more than 2 weeks, think of TB. Now we go to the third case. This is a 15-year-old boy. He has fever, evening rise of temperature, cough with expectoration for the past 1 month. Loss of appetite and loss of weight, no contact. Now you have fever and cough for 1 month. What are your possibilities? Fever and cough for 1 month. Let's not talk TB. Let's talk
parenchyma or lower, there will be pneumonia.
which pneumonia was gone for a month. Atypical will not cause fever. I have a fever and cough going on for a month. Fever, evening rise tells me this may be TB. But suppose I didn't have a history of evening rise. I just had fever and cough going on for a month. What are my possibilities? Fever and cough means respiratory. Respiratory going on for a month. Upper respiratory is out. Lower respiratory. Lower respiratory, again I come to trachea. Trachea going on for a month, not possible. Bronchus going on for a month, not possible. Alveoli pneumonia, yes. But which kind of a pneumonia? Suppurated pneumonia. Something that is causing a pus. So what will cause a pus? Lung abscess. Lung abscess can come. A pneumonia that is rapidly filling and growing back, getting reinfected again and again. Bronchiectasis. So fever and cough for a month, bronchiectasis, lung abscess, or there is a cavity sitting there. So these are my three differentials here. Or an empyema which has been missed. So my fever cough for 1 month is cavity, bronchiectasis, lung abscess, empyema. All of them will have loss of weight and loss of appetite. So how will I differentiate between 4 of them? Evening rise of temperature tells me that this could be TB. Okay, now which kind of TB? TB with bronchiectasis? TB with cavity? Lung abscess is out. Lung abscess will be fever continuous, not just coming down. TB with cavity. Why not bronchiectasis? I am saying this is bronchiectasis. How will I prove clinically? Examine the child. Before I put in the stethoscope. Clubbing. Yes, it takes time, but clubbing would have developed in 15 days in a bronchiectasis. Going on like this. Now this child, our diagnosis was either fibrocavitary TB or bronchiectasis. Clubbing, lymph nodes and malnourished. Those are the things we have to look for. This child does not have clubbing. So our diagnosis is cavity. We have not put in a stethoscope as yet. Now we are going to confirm it with auscultating. What did we get? Bronchial breathing on the right intraclavicular region. There is dull tone over the same area and decreased tactile vocal erythematous. Trachea is shifted to the same side and that side of the chest appears contracted. So there is fibrosis and there is a cavity. So this is fibrocavitary TB. So I got a diagnosis of fibrocavitary TB just looking at him and on his history.